Hi, today we'll be discussing about paradoxical upgrading reaction or paradoxical reaction PUR or PR in tuberculosis. Let us go quickly and discuss a case summary related to it. Now, a 13 years old adolescent male visited Vadia TB OPD on 24 July 2023 with complaints of left-sided chest pain, abdominal pain, cough and weakness in 6 months. Now, in prior drug history, he had already received anti-TB treatment for 2 months from Feb to April only, 2023. Now, outside in Feb 2023, he had presented with cough and weight loss since 1 month with history of contact of PTB in mother 10 years back. His chest x-ray was suggestive of TB as per the documents, and CECT was suggestive of necrotic mediastinal lymphadenopathy with normal lung parenchyma. Now, mind you, there was no microbiological diagnosis available. HIV was non-reactive. No microbiology in today's times is something which we don't want. But with the diagnosis of probable mediastinal lymph node TB, this patient was started from an outside practitioner with HRZE. Now, this algorithm is just showing the sequence of events. So, in February he was diagnosed, but within 10 days he developed drug-induced liver injury, because of which all the anti-TB drugs were stopped. It was not that that hepatosafe anti-TB drugs were started, and then he was restarted on first-line drugs. He took it for 2 months, went to village and stopped on its own. So that just means that he defaulted. Now, in July, when he came back to us, MDR TB was suspected. For microbiology, induced sputum expert MTB RIF was sent. MTB was detected. Reepa resistance was detected. Expert MTB XDR was sent, and even INH ethionamide resistance was detected. Okay. Now, his chest X-ray was showing bilateral pleural effusion, lower lobe bilateral consolidation, and ultrasound abdomen was showing splenic microabscesses. So this patient was admitted, started on second-line anti-TB drugs in July. A regimen comprising of bedaquiline, moxifloxacin, linezolid, clofazimine, cycloserine was started. He did develop certain dyselectrolytemia which were managed, and most importantly, he was intensively counseled about drug adherence. Nothing will work if he will not take the drugs properly. So it just started as a probable mediastinal lymph node TB, has now turned out to, unfortunately, a disseminated MDR TB comprising of pulmonary, mediastinal as well as abdominal TB. We subsequently got our microbiology further reports. So the sputum first line LPA detected resistance to isoniazide and ethionamide as well as rifampicin. Second line LPA thankfully did not show any resistant mutations for fluoroquinolones and aminoglycosides. DST proved it. It was sensitive to moxifloxacin, linezolid and pyrazinamide. Now, in December 23, when he was almost on second line since 5 months, he presented with midline chest wall swelling and vomiting. Chest X-ray was ordered immediately. But it showed no pleural effusion, and there was reduction in the consolidation as well. Now, we do follow up monthly. Okay, so this is the follow up in December, right? In between, the child was doing well during the monthly follow ups. Now, USG chest was suggestive of a cold abscess, okay, around 6 into 1.7 centimeter in size. So now, how do we manage this, right? So to manage it, we need to know what is happening. Okay, we need to recheck about the compliance. We know he had defaulted once. We had to check about any further resistance, any treatment failure which is happening, what is going on, or is it something new which has happened. Okay, so we kept in mind paradoxical upgrading reaction as well. Pediatric surgery reference was taken for drainage of abscess, and samples were sent for cultures, TBMJ and gene expert. Now, as we ruled out everything else, we started the child on steroids at low dose and tapered it after 1 month. Well, this helped the child, and USG's chest in February showed resolving cold abscess. Bedaquiline was stopped in February 2024, that is within 6 months. No extension was given. Cycloserine, clofa, linezolid, moxiflox were continued. Now, in subsequent follow-ups, his chest X-ray was showing improvement, GLMJ became negative, and USG abdomen just shows splenic granulomas. However, in July, he started complaining of blurring of vision. Linezolid was stopped and never re-challenged. After stopping in September, the vision improved. Everyone was happy. But in October, when he came back with a USG abdomen, so for our patients, 3 to 6 monthly, we do the imaging for our MDR TB patients. It is a very individualized approach. That had picked up a well-defined solid hypoechoic lesion in the right lobe around 2 centimeter in size in the liver, and tiny hypoechoic areas in mid portion of the spleen with tiny calcific foci. Now, what is happening and what does this suggest? How to manage? Of course, we will again rule out our poor compliance, any subsequent resistance which is happening, treatment failure, any secondary disease, any infection which is happening. Now, clinically this child was well, no fever, no pain, nothing. Okay, the child was well. Now, initially we waited, but we found that the lesions were increasing in ultrasound, the liver and the spleen lesions. So we labeled it as PUR and we initiated steroids. The cyclomoxiclofavir continued. Now the child responded to steroids, and in March 2025, recently when the child came to us last week, the USG abdomen was showing a decrease in size of the hepatic lesion and regression of 1 splenic lesion. So from 3 it has again become 2. Okay, now this child is still undergoing treatment, and we will be following up this child. Okay, it's been 20 months of second line AKT. Now, what are the reflections? So, what we wanted to emphasize here is that it's very important to have a microbiological diagnosis to begin with, which was not there in this child. We do understand in extrapulmonary TB it is difficult to sometimes get samples, but always try for a microbiological diagnosis. On top of that, this child defaulted, right? So we don't know whether it began with resistance, Reepa resistance, or did he subsequently develop it. Now, this child had 2 episodes of PURs, okay, on treatment. One was at 5 months with chest wall cold abscess, and the second one was at 15 months, that is hepatosplenic lesions. He also developed an ADR, linezolid, related to linezolid, that is optic neuropathy. So just wanted to bring to your attention that treating a child with MDR TB is not easy. It's not easy for the patient as well. They undergo so many things. They undergo paradoxical reactions. They need to take the medicines. They are on 3, 4, 5 medicines, and they have to take it. Compliance is an issue. They get hyperpigmentation with clofazimine that I have not even mentioned. It is so common and we just accept it for them. So it's very important that a close follow-up is taken, and at every visit the child is motivated to take medicines and to re-emphasize that with anti-TB drugs his TB will go away. Okay, so let us discuss in details about paradoxical reaction. So paradoxical reaction in tuberculosis is defined by a clinical, or radiological worsening of pre-existing tuberculous lesions or the development of new lesions in patients receiving anti-tuberculous medication who initially improved on treatment. So most important is that this patient was initially improving on treatment, and then later there was a clinical or radiological worsening of pre-existing or new lesions were developing. Okay, now what is the mechanism? So mechanism is basically an abnormal immune response or reconstitution of the immune system, and that is why it is commonly seen in HIV co-infected patients. Now it's extremely important to remember that it is a diagnosis of exclusion, and every time before labeling it as a PR and treating it as a PR, please rule out poor compliance, drug resistance, progression of original disease, and any secondary diagnosis. So mainstay of diagnosis is negative mycobacterial cultures. And how do we manage? We manage by using anti-inflammatory treatment. Now the pathogenesis, as I already mentioned, is immune driven, but this immune driven to what exactly? To residual mycobacterial TB antigen in tissues. Okay, so it is an immune driven inflammatory reaction to the MTB antigen in tissues rather than treatment failure or microbiological relapse. Now what is the incidence? So incidence can be anywhere between 2 to 23% has been described in literature. And what are the sites? So sites can be your CNS, like tuberculomas, or pleural diseases like pleural effusions. It can be skin lesions, lymph node lesions. These are most common sites. Other sites including bone as well as hepatosplenic lesions. Now, due to the favorable prognosis in lymph node TB recurrent symptoms, a short period of observation is warranted, okay, to assess for spontaneous regression, right? So wait and watch can be done if it is just lymph node, but if it is CNS and there is recurrence, then of course anti-inflammatory like steroids, thalidomide, and a possibility of, if it is happening after TB treatment completion, then even TB retreatment should be undertaken. So now the question is when to use steroids. So one has to use steroids if there is persistent fever, there is a massive pleural effusion, the lymph nodes are not regressing, okay, and there is endobronchial TB, or there are tuberculomas. Now except tuberculomas, it can be treated with low dose steroids for over a month, like 0.5 to 1 mkd, and then tapered quickly. But if it is a tuberculoma, sometimes they may require prolonged treatment and then tapered over 3 to 4 months. Okay? And these are certain references. Thank you.